Perfect. Well, welcome everybody. My name is David. I'm a consultant neurologist in Sheffield, and it's my pleasure to announce today's webinar and share that the last webinar of the year from the MS Academy. This current webinar has been supported with sponsorship from Roche, but the sponsor has no control over the educational content of this activity, and there's no symposium afterwards. This is what we're going to talk to you about today. So I'm going to provide a short welcome and a case study to get us in the mental headspace to talk about functional neurological symptoms as they pertain to MS. Rachel's going to then talk a little bit about functional neurological disorder and how it's related to MS. Alex Phillips is going to talk about care coordination. Lee Drake is going to talk about treatment and management. I imagine this will be quite a interesting session for a number of people on the webinar, and I know we've got a very wide range of expertise and professionals, so we've got lots of time for questions. We're going to try and extend on to 5:15 to try and answer all your questions. As you go along, please put any questions you have in the Q&A function. We'll answer them at the end, but you're very welcome just to jot them down there as you think about them. I'd like to take a little bit of time to introduce our speakers because understanding their expertise, I think, will be really helpful in us getting the best out of the webinar. My first speaker is Rachel Newby, who is my consultant colleague who has a special interest both in movement disorders and functional neurological disease. Rachel has an extraordinary research, clinical, and intuitive understanding of functional neurological disease, particularly that difficult interplay that we have with organic disease. And I think Rachel's framework for understanding these conditions and helping the patients will be incredibly valuable to us today. Next, we have Alex Phillips. Alex is an incredibly interesting person with a very interesting job. He has been viewed by a number of my colleagues who found his insights into how to create a holistic care package for people with functional neurological symptoms to be really inspiring. And Alex is going to talk about how we'd help a patient like ours based on some of the work that he has been doing at St. George's Hospital. Lee Drake is another colleague from Sheffield. So Lee initially trained as, he is a physiotherapist with special interest in multiple sclerosis, but more recently he has been doing both clinical research work in functional neurological disorder, and Lee will be able to provide us some insights from both of those conditions, and he has a very interesting insight into how he manages those. So I think that's going to be really helpful today. I hope by the end of the webinar we feel more comfortable in diagnosis functional neurological disorders in people with MS, that we learn, particularly from colleagues with special interest about this, about a modern understanding of functional neurological disease, how we use that to feel more comfortable in communicating this to our patients to help them understand, and our colleagues to help them understand and to help us holistically manage people, and how we can feel more confident in supporting people with functional neurological disease to improve their symptoms. To frame this, I'd like to talk about a case that I had. It's a 37-year-old lady who we'll call Anna. Anna has a background of migraine, depression and anxiety, and polycystic ovarian syndrome. In January 2022, Anna had a fairly classic episode of right-sided optic neuritis. She had some features in keeping with an optic neuritis at the time of review. Examination was otherwise normal. And as in lots of people with optic neuritis, she had an MRI scan of the brain, and it showed a lesion in the optic nerve, but a couple of lesions in periventricular areas. So at that point, we couldn't make a diagnosis of multiple sclerosis, but we were concerned because of these extra lesions in the brain, and we made a diagnosis of clinically isolated syndrome. We sort of went forward and back on whether we should do extra tests, but they wouldn't particularly change her management. So we arranged that she'd be under review by myself and the MS nurses, and we booked another scan for a year. Later in that year, she contacted the MS nurses with some fatigue, headaches, and nausea. We actually opted to do the MRI scan a little bit early, and that wasn't changed. So we felt these symptoms were non-specific. She had her MRI scan the next January with no new lesions. And in March, she contacted the MS nurses with some new symptoms of fatigue and balance symptoms. At that point, she had a new lesion. She had a lumbar puncture. It was positive for oligoclonal band. She had very mild unsteadiness on her examination. So at that point, we were able to make a formal diagnosis of multiple sclerosis, but actually a very early stage in her disease. In July, she started ocrelizumab. I saw her in September of 2023. She was doing incredibly well. All her symptoms had resolved. She felt quite happy and optimistic. She then had an episode in January. She contacted the MS nurses and at a party, she had a rather unusual constellation of symptoms. She got very distressed. She forgot where she was. She forgot her name and how to get home. And actually, since that time, her memory felt much worse. Her family felt that someone had to be with her off the time. She was permanently off sick from work as a nursery nurse. We saw her the next month. Examination was normal. MRI scan was unchanged, but she still had quite a lot of cognitive symptoms. And then in March, she started getting episodes of reported spasms. She started pregabalin, but a couple of days after starting pregabalin, felt that she wasn't able to walk and was very dizzy. She was told that she'd had a drug reaction and she had to stop the pregabalin straight away. An MRI scan was arranged, but actually in the interim, she had much more difficulty walking and she had much more severe episodes of spasms. She attended A&E and she was given some morphine. And then later in April, she attended A&E again with some back pain and walking difficulty. This had progressed to the extent that she needed a frame. She had lots of spasms and pain in her legs, lots of cognitive symptoms, found it very hard to recall dates. And she was admitted to hospital where she had an MRI scan of the brain and spine. I saw her in hospital and she was pretty unwell. She was photophobic. She had a lot of pain in her back, both legs, particularly on the left, where she found it very difficult to move. She required regular morphine. She had stutter. When I tested her power, it was she had a giveaway component. She wasn't able to fully exert power on the left arm and leg. And actually, it was very difficult for her to move the left leg at all. But in other instances, when she was walking with a frame, she was able to sit unsupported, her leg would work much better, and her Hoover's test was positive. So at that point, I made a diagnosis that she's got a functional neurological disorder in addition to multiple sclerosis. And that neatly curtails into Rachel's presentation, who will take us through the next step about what a functional neurological disorder is, and actually some of the relationship with multiple sclerosis. Rachel.
Thanks. So I think the first thing to say is that functional neurological disorder is quite a big topic. So it encompasses a whole range of different symptoms and signs. And it's a little bit tricky for that reason to condense it into a neat package. In terms of how it's defined within the DSM, the criteria have recently changed. And according to those criteria, it's defined by one or more changes in sensory or voluntary motor function. And those changes have to show some level of incompatibility with known patterns of neurological disease. There oughtn't to be an alternative explanation for those symptoms, and they ought to be causing disability either in occupational or social functioning. So I think, you know, to try and keep it a little bit more focused, I thought that it would be sensible to try and focus on this case specifically and look at some of the things that are relevant specifically to this case. So I think that highlights an important point. One of the things that can trip people up when they're diagnosing functional neurological symptoms and indeed discussing that diagnosis with patients is an underappreciation of how heterogeneous as a condition it is. So the particular factors that have predisposed an individual to a functional neurological presentation, or the particular factors that have triggered it or are perpetuating it, vary considerably from patient to patient. So, 100, 150 years ago, there was a theory that this was a condition that arose because of sort of deeply held emotions or experiences that the sufferer didn't feel that they could process emotionally, and so it was converted into physical symptoms. I think we've got a better appreciation now of how rich the phenomenology and the etiology of FND is, and whilst it's not completely understood, like any number of neurological conditions, we do have a better sort of biopsychosocial framework for these conditions. So just looking at the case that David has presented, there are a few different things that may have predisposed this lady to developing a functional neurological presentation. So as he's mentioned, she's got anxiety and depression. Both of those can have the effect of drawing more attention to the body. That's both typically associated with physical symptoms as part of how they present, and that can, as we'll discuss later, be relevant because there is a strong role of attention, and body-directed attention tends to exacerbate functional symptoms. As individuals with experience in MS, I'm sure that you have come across a number of patients who, for a period of months or even years, have carried a diagnosis of clinically isolated syndrome. And my experience is that a lot of people find that very difficult. The uncertainty of, am I going to develop MS? Am I not? Is almost worse than having the diagnosis of MS and it being, well defined. Also, another predisposing factor is that she's got another neurological condition. So that is one of the features that increases the risk of functional symptoms. So there's a close interplay between the two, and we'll discuss in subsequent slides how that might be working. In terms of triggers, there can be a bit of an overemphasis on there being some emotional turbulence that has precipitated these symptoms, and quite often that's not the case, particularly with functional motor symptoms. Probably more often it's a physical illness or an injury. And for this lady, part of the genesis of her condition is that she's had a drug reaction. So she's taken pregabalin and had side effects with that, and shortly thereafter developed functional symptoms. She's also got a background of migraine, and in the run-up to developing these symptoms did have some features of that, some headache and nausea. And then it's a little bit harder, just from this snapshot to understand what might be perpetuating her symptoms. But obviously there will be naturally a concern that her symptoms are representative of an MS relapse, which would be particularly worrying in someone who's already on disease-modifying therapy that's highly active, and concerns about the future. It's also the case, and we come across this a lot, that interactions with healthcare professionals aren't particularly positive often when people present with functional symptoms. They can have an appearance of a sort of voluntariness. The way I think about functional motor symptoms is that it's as if someone has hijacked the voluntary motor system, so people are no longer in control of their actions. They no longer have a sense of agency over their movements. and people can have some strange reactions to that, and often quite negative. So we see that certainly within the population that come to our clinic, that can be a perpetuating factor, but also commonly diagnostic uncertainty, or some patients are very fixated on their symptoms having a physical basis. So what are the signifiers of functional disorder? So I think this is important. It was perhaps at one stage considered a diagnosis of exclusion. If you did all the other tests and there was nothing wrong, then it was a functional disorder. But like any other movement disorder, it is something that you can diagnose clinically based on the symptoms that we see. Part of it is the history. Commonly functional symptoms appear quite precipitously, quite suddenly, and that was the case with this lady. There are also some physical signs that are important. So David has already mentioned sort of give way weakness. So individuals are able to achieve full power but aren't able to maintain it. So there's a sort of give way pattern that often associated with quite a lot of effort. It looks effortful for people to move, even make simple movements. And then there's the sign that David mentioned, Hoover's sign, which is a useful and quite common sign in functional neurological presentations. So I've just got a quick video of that, and then I can talk you through that and how we use it. So I'll play that now.
Press this heel into the ground as hard as you can. That's normal. And push this heel into the ground as hard as you can. That's weak. Okay. And then just lift this knee up for me. Keep it in the air. Stop from pressing down. Focus on that leg. Really stop from pressing down. And when we do that, you can feel the right leg returns to normal. Okay, that's good.
So that's Hoover's sign. So when you extend one hip, when you lift one leg up, the other leg automatically will press down. That's a reflex, and it's designed to stabilize the pelvis when we walk. So it doesn't require any thought, any conscious willing of movement. And what it demonstrates is that in functional disorders, there is this disconnect, we often describe it as a software problem. So when individuals are thinking about movement and trying to will movement, they're unable to engage those muscles, and there is the experience and appearance of weakness. When the same muscles are activated via a reflex, then the muscle is strong and that movement can't be overcome. And it's really quite useful if you understand that and you're able to demonstrate it to the patient. It's really quite therapeutically useful in helping patients to understand what functional disorders are. We can use words like software problems, but oftentimes I've found...
No, I got really sick of and he was there and then I ran away.
Sorry, I think somebody's unmuted. Okay. So oftentimes that will be a real light bulb moment for patients when they see that there is that disconnect, and it helps them understand the role of attention. Very often, the more that individuals are thinking about the movement, the worse it gets. And if you're able to distract patients, the movement can normalize. And I think Lee will be talking about that a bit later. She also had considerable disturbance of her walking, her gait. So I've just included a couple of videos of the type of gait disturbance that we see.
This patient demonstrates several features of this.
Mute the sounds that you can see. So this gentleman has a knee bobbing gait. Often functional gait disorders are associated with a lot of effort. There's the so-called huffing and puffing sign, which we can see more frequently in functional movement disorders, because movements are less efficient, they're harder to execute, and you can see this sort of knee bobbing tendency. And another type of functional gait disorder is demonstrated here. So very slow, very laboured, so-called walking on ice patterns. So someone looks as if they're walking on ice. They're very wobbly, but often there'll be a lot of truncal swaying without loss of balance. And this sort of toe dragging gait that this lady is demonstrated, we see quite commonly. And there are inconsistencies that you can see. So when you're specifically examining gait, it tends to be worse because the patient is focusing on it. But if you engage them in conversation as you're calling them through into the clinic room, it may be a bit better if you ask them to do something like sit on a wheelchair and walk on the wheelchair, because that's a sort of unusual situation and they're thinking more about that than they are about walking. The gait pattern can be better. Or ask them to pick up a chair and walk with it. Again, it's just shifting the attention away from the action of walking. So in terms of how we understand this, there is a theory of how the brain works, for which there is a lot of evidence, and which is quite useful in understanding how functional symptoms are generated. So this is a theory based on Bayes' rule and predictive coding. And what Bayes' rule describes, it's something that we use intuitively every day, is that there is a prior probability, which is this purple probability distribution here. And that's essentially a guess. So your brain can't, it's got no access to the external world except through your senses. It can't get out and walk around and work out what's going on in the world. So it's all the time, if it had to work everything out from first principles, it would be too expensive in terms of energy. So what it does is it makes a guess, and that guess is based on previous experience. So all of your experiences in your life, your brain stores those experiences as prior probabilities or expectations about what might happen. And what it compares that guess with is the sensory feedback that it receives. So, and then it refines the guess. So this is your feedback, and then you've got a posterior probability, which is the composite of the guess with the feedback that the brain receives. And this is how your brain codes movement. So it makes a guess about the sensory consequences of a certain movement, and then it compares where your body part has got to with the feedback that it's receiving. And the idea is that the brain is structured in this way to minimize what we call prediction error, which is the difference between the guess and the sensory feedback. And the reason that's important is if there's a big error between those things, if you're constantly misguessing, then you're probably not going to be moving through the world in an efficient way. You're probably not going to be using energy in an efficient way, which is obviously not good for survival. And you're more likely to be surprised by events happening in the world, which again is not good for survival. So the idea is that you want to try and refine these guesses and make them as accurate as possible. And that's an iterative process throughout your life that is refined, and it's organized in the brain in a kind of hierarchy. So things that are stable and unchanging. So for instance, I'm going to show you this video, which is of a tennis game in a second. So the idea that the ball will obey gravity is stable and unchanging, whereas an appreciation of the speed of the ball and its direction is much less stable and more changeable. So that's encoded at low levels of the hierarchy in the brain, and those stable things are encoded at the top. It's important to try and minimize prediction error, that you get the balance right between your guesses and how much you weight them and the feedback. And if that balance is lost, then you tend to get more prediction error. So when it's working really well, you get things like, so this is Federer, so one of the best tennis players of all time, and this is a particularly stunning exchange. So that's someone who has refined his motor prediction so well and understands the game and can bring together what his body is doing with what the ball's doing and other factors such as, wind speed, etc., that he can play tennis at the very highest levels. Functional movement disorders, on the other hand, are a complete breakdown of this process. So the theory is that at some level of this hierarchy within the brain, there is a guess, which is one way of thinking about it would be a certain motor program that's running without being updated. So it's become strengthened, and attention towards the body has the effect of strengthening this motor program, which can also be thought of as a set of expectations about movement, so that it's not appropriately compensated by feedback. That can be quite a dense thing to try and put across to a patient, and I find that it's quite useful to use analogies. So if you're talking about a motor problem, one of the analogies I use, which is accessible to most people, is, and most people have had this experience, you go to pick up a suitcase that you think is really heavy, and unexpectedly it's light, and so what happens is your arm shoots up. Now, once that has happened, if your brain is working normally, you correct for that, and the next time you go to pick up the suitcase, you will scale that movement appropriately and your arm won't fly up. In functional disorders, that correction process, that integration of the feedback and the motor program isn't happening as efficiently. So it's almost like someone keeps, imperceptibly changing the weight of the suitcase, so you can't adjust your movement scaling appropriately. And most people can understand that as a concept because they will have experienced it at some stage. Looking more at the kind of sensory side of things, you can bring in the effect of attention on how your brain perceives things. So that's one way of thinking about attention, as a sort of filter that's going on in the background all the time. So, and it's happening without our conscious awareness. So I'll often say to people, you're sitting here, until I say it, you're not aware of the feeling of the clothes against your skin, not because that you stopped sensing that, but because your brain is ignoring it. It's not interesting or important information. Your brain is trying to make you only perceive and aware of important sensory information. In the same way, if you're walking down a street on a bright sunny day, because we're very visual creatures, you prioritize visual information. But if you're walking down the same street in the middle of the night, you're going to be much more sensitive to sound, because your vision is less good. And that switching of the volume switches for different sensory information, that very fine process isn't working as well in FND, we think. So it's as though all the volume switches have been flipped up, And people often describe a lot of sensory sensitivity with FND, so they can be more sensitive to light and dislike very loud, busy places because it's so overwhelming. So there are little analogies like that can make it accessible. And I think that's often a way of explaining these symptoms in individuals with another neurological condition that's useful, because there is something, there's a problem with the hardware for them that is affecting the way that the way the brain is perceiving things and integrating those perceptions with movement. So yeah, I think that's, I only had 15 minutes, so there's quite a bit to fit in, but happy to take questions at the end, and hope that was useful. I'll hand back. I think Alex is next. So I'll stop.
Hey everyone, I'm Alex Phillips. I work out of St George's Hospital as a FND care advisor for South West London and Surrey. I'm very sorry, I've started getting these notifications. You probably just heard one. So I tried desperately to find a way of turning them off, but I can't seem to. So you'll get the odd ping as I talk. So apologies. I've got no conflicts of interest. And I'll go straight into the case study. David, are you happy for me to talk to until about 1:45? Is that okay?
Yeah, perfect. Yeah.
Okay, so coming on quite nicely from everything Rachel just said about, well, you can have an entire talk on what FND is, and there's some really nice literature out there about talking about the diagnosis, and I think that's really such a vital step for these patients, and especially when you have a mixed picture where you have someone with a neurological disorder and another neurological disorder in FND, and that works comorbid, because I think it starts to get more complex for the health professionals involved, and it also starts to get more complex for the patient as well. What symptoms are to do with my FND, what symptoms are to do with my MS, how do I start to untangle those? And they have different treatments, and some of the treatments overlap. So sometimes it can be, and completely depending on the healthcare professionals involved and the patient as well, sometimes it's quite nice to make a nice clear distinction between the two. Sometimes it sounds like in this patient, she's got multiple symptoms of FND and kind of more of that syndrome form with pain and fatigue, and this circular thing on the right-hand side of your screen just talks a little bit more about the kind of FND as a syndrome, and you have the kind of core neurological, sensory and motor changes, and which can happen. And as Rachel said, it's very heterogeneous. It's really different in different people. But then some of the other things that go alongside it. And in that case, it can be quite nice for the patient to have that all kind of put together with kind of a single diagnosis, and that being separate from their MS. Because if I put myself in the shoes of this patient, I think my instant concerns would be, are they sure this isn't MS? I've been told that I need to be watching out for these like for the next relapse. This could be really life-changing, the next relapse, and so you're going to be self-monitoring a little bit more. So having that confident, good understanding of the diagnosis given to you by someone who really knows what they're talking about is really, really helpful and invaluable. And then if I had this patient, I would be asking, so how are you worried about anything? Is there anything, do you think it's something else? Do you, like, are you happy that things have been investigated? Do you, because if there's some niggling doubts, then some you can put to bed, some you can put back to the doctor who's made the diagnosis, and try and get that conviction a little bit more. And that can be a really nice time to open up that conversation around, well, actually, let's have a look at your Hoover's sign again. And I know that's Lee will be talking about that a bit more in physiotherapy as well. It's the trick or treat, where the diagnostic signs and tests can be used as a treatment, really, to show the patient and help them understand the kind of difference between that when the harder you try, the harder it doesn't work versus the automatic movement returns when there's a redirection of attention. And I think if I was this patient as well, if I then started to embrace this diagnosis more and more, then I'd be like, well, that's all very well, but what happens if something new comes along? Like if just because this has been explained, I could still have another relapse of MS. How can I tell? Now it sounds a lot more confusing. How am I going to tell if this is FND? How am I going to tell if the next thing's MS? It's not. So I think, and that can having that chat with your patient too, and well, actually, I think one of the reasons to have a better understanding yourself about your FND symptoms and really get to the bottom of it will help you with your MS as well, because it will help you understand, well, is this my FND symptom? Is this something new? And I think it's important to have that conversation too with any patient, is that you're not immune from getting anything else as well. Like you can have a range of symptoms. It could be very heterogeneous with FND, and it can move around a little bit. It can feel like whack-a-mole sometimes. I know that's been described in the literature, but that doesn't mean that new symptoms shouldn't be investigated and should have been looked into properly, which can tie in nicely sometimes with looking at one of the big things Rachel mentioned at the start, which is what have their interactions been like in the last couple of years with healthcare professionals. It sounds like this patient's been coming back forth a bit in out of A&E, some chronic pain presentation, some back pain, I imagine they've been to their GP a few times too. Do they have kind of the supportive healthcare professionals around them, or do they feel like they're being dismissed or turned away, or even sometimes, oh, that might be part of your MS, that's too complicated for us, you need to go speak to your neurologist, and they're getting a lot of mixed messages from everywhere, which tends to. So those kind of things you can start to tease out and help the patient. I think you've always got to believe that your patient's got the most resources and the most ability to self-manage their own condition, and they're the ones that got to be in charge. But you can start to get to the bottom of some of these factors with them. And I think this comes to my big picture on the left, which is sorry, on the same slide, which is sometimes it's about treating everything else. It is, and this seems very complicated, but actually it's just how you treat any other condition, really. A confident diagnosis, given by someone that knows what the condition is. And then more and more, we're encouraged to look at things as an individualistic approach from a kind of biopsychosocial, looking at all the contributing factors. I know every single disease, there's countless examples of where scans can show something's terrible, like you've got things are really at the kind of severe and at the end, but they kind of walk in and they look all right. And then the opposite, where they've got something mild on their scans, and everything's absolutely fallen apart. And we know that in a lot of cases, in a lot of different conditions, the kind of underlying illness isn't necessary, is an absolutely terrible predictor of kind of the severity of symptoms anyway. So it's a little bit about just treating the human around this. And whether that be, well, if this person came in with gait problem, spasm, with weakness, we would usually send them to physio, wouldn't we? If there was any other condition. So why wouldn't we send this group to physio? And actually they do quite well with them. If they have, it's been so caught up with mental health with such a long history and kind of part of the stigma that, but if we knew a patient with any other condition had anxiety and depression, and we know anyone with chronic conditions are kind of more susceptible for that getting worse, it's chicken versus the egg as well. You're now having to face a completely different challenge life with MS. Has that become a big part of what's happened in the last 2 years, and does that need to be addressed? And does this need to be addressed in a step-by-step approach? Is it that, oh yes, I think your walking is really off and your balance is really off, but we can see that actually you're just really not coping with this MS diagnosis. You're a bundle of health anxiety right now. Everything your depression's been really bad. You've been telling us ever since. What's happened with your work? You were a nursery teacher. Are you still in that job? Or what are all of those other factors? This isn't the right time, because you can kind of get lost in the, well, oh, what's the treatment for FND? Well, actually, it's physio's got some of the best evidence for it, or CBT, let's send you on. Is it the right place and the right time for that? Or actually, by doing a little bit more of a biopsychosocial, as you would do for any patient, and if you spend the time to do, find out what some of the factors, and probably what you'll find is that you'll find these precipitating and perpetuating factors come up, and there'll be room for treatment within them. For her, she's got migraine. Is that been treated? We don't know from the case study, but we know that I think Dr. Coburg's quite interested in, if you treat migraine successfully, it does have a big impact on functional symptoms. So could that be something as a way in? Has that got a lot worse? I can see she's now on a lot of opioids, I think, in and out of A&E. Has that contributed to her headaches? Has everything kind of got worse? Yeah, anxiety and depression we talked about already. We talked about work. How has her life changed after a big diagnosis like this? Other things, is she worried that she's got early onset dementia and things? I know cognitive, and has that been cognitive symptoms can cause a lot of worry in people. People think they're kind of heading down. And has she got a family history of any dementia or anything? Is it something completely else and it's not to do with the MS or the FND that she's worried about? And does that need to be just addressed? It's like, well, actually, we can tell, like with a neurologist or a thing that we're like, this is why they're functional cognitive signs, and they're not a worrying sign for thing. But that might be their biggest worry, and that might be, in a sense, helping to perpetuate all of the symptoms. And then sometimes it is just, oh, well, actually, these factors we can see aren't the major things, but we can see that you've got a big disconnect between your body and your balance and your walking. Physiotherapists, off you go. Or that actually we think that there's a lot of other things going on here, and you may need some kind of mental health support, or maybe you need some social support. You actually just haven't been managing at all. You've got 2 young kids and you were previously working and now you're not, and you've been really worried about kind of getting any kind of support or any kind of help with that. Do you need that all kind of addressed first? And I guess that's where the kind of care advisor role can come in. That's probably talking to death about all of that. So if we go to the next slide very quickly, because I do want to give Lee a chance to speak. This is just a overly complicated framework of an ideal model of what you could do for these patients. And it is actually quite nice when the more you spend a bit of time with it. But basically, any new neurological signs and symptoms should be like investigated, like anyone else. And then that should be kind of managed at a general neurology level. And then general neurologists should be comfortable giving a diagnosis of functional symptoms or functional neurological disorder if they feel like it's kind of like a kind of big label is more needed. And then they would make a management plan and feed that back down to local and community services. Some areas, like my area, are really lucky that we have a kind of first point of contact who can, in more complex cases, help kind of then guide the management plan, make sure the GP does know, make sure the community teams kind of are involved, and just get everyone talking together as much as they need to. But I know that's not really the case for most of the country. Make sure the GP is really well on the band, and then you can use the subspecialty regional services and the national services for cases where there's diagnostic uncertainty, where there's kind of a severe, unmanageable set of symptoms where they're getting worse despite local input, and you can kind of have a more stepped approach. And then also just looking out what are your local pain and local fatigue services too. That's something I didn't touch on in the case studies, but actually if pain is more of a dominant presentation, and then does this patient actually would benefit being managed by a chronic pain service and have all those kind of medications and a kind of a joint MDT input, because there's some great services across the country for that. And then you would come down after that into the kind of national and contrary services, I think they call them on this. which I've just got some resources at the end, which I'm sure we're still sharing the slides, I think, so you'll be able to access afterwards. So next slide is just what the local services, which I've spoken about, support local. And then next slide is just kind of a list of the national services. I'm biased. I know the London ones quite well. Outside of London, I don't, because of course my patients are from London and I'm not going to send them up to Leeds. That's not fair on them. But it's growing and growing, and FND Hope is quite a good resource just to see what kind of centres are out there. And then next slide is I've just put together a list of some are professional bodies for people who are kind of interested in FND. The Society, the UK FND network's only recently been set up, and it's got some lovely resources about how to set up FND services and how to kind of look at health economic costs and things as well. All of the charities as well, which are great resources for the patients. And some of them, the Brain Charity happily accepts FND and sometimes has some extra resources which aren't just specific to FND. And yeah, non-epileptic tax is a really good website with I think it comes from your neck of the woods. Yeah. And then there's the app and of course there's neurosymptoms, but try not to be the person who gives a diagnosis and just gives neurosymptoms, because I think that's become a bit of a thing. So I'll move on, and thank you very much for letting me talk.
So hello everybody, my name's Lee Drake. I'm a physiotherapist at the Hallamshire, and part of the reason I'm doing this talk is I was involved with the physio for FMD that was run out at St George's. And that's started 2018, then got stopped for COVID, and then it started back up again. But that's now finished. And so that's kind of my background and my experience of going through that and tying it in with this patient. So if we just move on to the next slide. Thank you. So I think first, it's highlighting that there's fundamental differences between how we treat MS and FND patients, and I think that'll probably tie in with what Rachel said and Alex. So FND, you're focusing on function and automatic movement rather than the impairment, whereas MS, you're focusing on the impairment and voluntary movement. So quite often trying to give them strengthening exercises, aids and adaptations, AFOs if needed. Whereas with the FND patient, you wouldn't want to go down that route initially. You might have to if things don't improve, or they might have been sent out of hospital with certain things. But again, it's that difference in fundamental difference in approach that's worth and I've been guilty of it of being undone by that, and I think that's where some of the physios do struggle, in that we're focused on impairment, and that's where it can go wrong, because going to this case today with a left-sided weakness, if you just sat there and give her strengthening exercises and told her to move that left leg, then that's just not going to have any effect. But as David said with the slide, that when she was walking with the frame, she was actually taking more weight through her leg. So it's the functional aspects that we're trying to tap into. And I think also it's worth bearing in that the physical assessments and attention-full movement, so that's, you're going to see a bigger impact with the FND patient. So when you're doing 10-meter walk tests, the patient might walk in relatively quickly, but then when you're focusing on a test, same as with a balance test, then you start to see these anomalies that you get used to seeing, that you kind of like, oh well, that doesn't kind of fit. Maybe this is more of a functional presentation or functional overlay. And another conversation, that Rachel and David and myself were having, was in terms of this patient, because her FND symptoms FND load far outweighs the MS load in disability, then the common consensus is that this patient needs to be given the diagnosis of FND. But quite often I'll see MS patients that have got balance issues that are kind of are having an impact, but and in that kind of case, I won't say that they've got FND, and I don't know putting another giving them another diagnosis when they've got limited changes from that. But I will often treat them as I would treat an FND, or have an aspect of my treatment that would be that I'd use with FND patients. If we could just go on to the next slide, please. Thank you. So some of the physiotherapy treatment principles, creating this expectation of improvement with F&D patients and projecting confidence, because quite often people don't have that experience. So I think it's important that we do that. And like we're saying, a lot of these patients do have negative experiences with the MDT. Open and consistent communication between MDT, patient, family and carers is really important, and I think especially when you've got a dual diagnosis as well, so that everybody's as open and clear about what's going on as can be. And I think especially around education, use a symptom model, and including the family with that is really important. So they seem to get a lot out of being part of that education session. And again, this is a brilliant resource. If you Google the physio for FMD and FOR's numerical research, there's open source to the workbook, the symptom model, and also the treatment book that we use. So yeah, that's really good. In-depth subjective assessment, so taking quite a time to talk through the subjective with the patients, finding out what negative experiences they've had. I know, talking to David, this patient had a morbid fear that she was going to end up in a wheelchair, and it's getting all that information quite often, again, which was a game changer with the research. Spending an hour doing a subjective assessment, getting a 24-hour picture of what that patient's doing, and a lot of information pops up that and health beliefs that you can use to address their health beliefs. Limited hands-on treatment and equipment. Encourage early weight bearing with this patient and functional tasks, and we're fostering independence and self-management. So yeah, the physiotherapy treatment we're looking at, we're looking at a sequential motor learning approach. So we're looking for symptom-free movements that we're establishing, and then building upon this in successive stages, and building on the complexity of the movement, building up to the complexity of walking. So what that means is we start to look at sitting posture. So quite often this patient's got a left-sided weakness, so they might be adopting maladaptive sitting postures where the left leg's extended, it's not mirroring what the right leg's doing. So we start addressing that, and explaining that using the homunculus and about the sensory input. Then we start looking at sit to stand, and then we'll start looking at walking. And through those stages, we're using video, so find it very useful to video the sit to stand, and have a very collaborative, make this a very collaborative process, and have a collaborative discussion with the patient, watching the video of them sit to stand. What do they want to make better? What can they identify that's going wrong? And then start to address that. So work on sitting posture, work on sit to stand, and then just building the complexity as we feel that it's progressing. Also the use of a full length mirror. So we have a mirror in front of the patient, and that helps provide feedback to them, and also it externalizes their focus of attention. So because we think this is the heightened internalization, that mirror image of themselves, that they're focusing on that, and that greatly improves the effectiveness of the treatment. Education around pain and fatigue management, using treadmills as things progress with mirror feedback, and then and all throughout this process, giving the patient evidence that, or feeding back to them, or through the mirror and through video as well, that normal movement is possible, and bringing their awareness to the fact that they've just moved nicely on turning, or and things like that. And the workbook's brilliant because it's a resource that they keep, and you're working through the strategies, and it's about 50 pages long, so it's quite in depth, but it's and they also do self-reflections on the on each treatment. So they write what went well in the treatment, what they learned, and we do this for every treatment. And I think another thing that came out of doing the research is the intensity of treatment with these patients. It's no good seeing them in like once a month. There needs to be some intensity, so you're making these changes stick. Whereas if they're seen quite far apart, it doesn't tend to be as effective. And on the study, we were aiming to see patients 8 sessions over a fortnight, and the sessions were an hour long. Now, some patients can't tolerate that, so you do have to obviously change that. But if you can aim for that kind of intensity, then that does seem to have a greater result.
Thank you so much, and it falls on me to thank all our speakers for the incredible talks that I think have really unpicked all the complexity that we're trying to deal with that patient. Ladies and gentlemen, we've got about 15 minutes that we can use for some questions. We've got a couple of questions on the Q&A, but if there is anything that you'd like to ask myself, Rachel, Alex, or Lee, you'd be incredibly welcome. Musa Watilla has got the first question up, and Musa asks, how do we deal with the requesting investigations that may not be necessary? The patient presented had more investigations than may have been necessary. What an interesting question, isn't it? And I don't know, Rachel and Alex, you alluded to this. You know, when do we investigate and when do we just appear confident? Rachel, do you have a feel for that?
I think it is a really good question, and I don't think it's an easy one to answer. There's certainly not a blanket answer. I think you have to, you know, as we've said throughout the presentations, you have to look at the patient and tailor your decision to them. Alex made the very good point that just because you have a diagnosis of FND doesn't mean you can't have other diagnoses, and that's one of the traps that some clinicians fall into, and it's a source of immense frustration for a number of patients because everything is you know, ascribed to FND. I think as a general principle, you know, it is important, it can be counter-therapeutic to do too much investigation. So I think that's where it's important as a clinician to be a bit self-aware and think to yourself, am I doing this to assuage my anxiety or because it's clinically indicated? I think, you know, we're anxious about not missing things, so that can be the case. I think try and be stick to the clinical signs, and I think if it's a functional presentation that's very similar to one that they've had before, you wouldn't necessarily need to do a new set of investigations. But if it's something new, there's often a complex interaction between an underlying neurological condition and FND. So
And Alex, you mentioned that it was really important to investigate properly and appropriately, and use that to, I suppose, build your bond of trust with your patient. Can you overdo that, do you think? Is Musa right? Do we actually order too many tests and create this situation?
Oh, for sure. Yes. Yes. I haven't had a chance to read, but I think there's a paper just out called Potential Iatrogenic Harms to FND. And I wouldn't be surprised if it talks about over investigation at times. So I know from my training as in physio from A1, it's like the kind of red herrings of investigation. You'll get disc bulges flow up, and like that. So she came into ED with back pain, and you get a CT done, and you get it doesn't really get explained, but here's some opioid medications, and you've got a bulge disc. Is that going to get better? Is that going to get worse? It's suddenly you've got all of these other things, and if you as Rachel said, it really depends on your patient. If you've got someone who's more health anxious, and has low kind of health literacy and understanding, you can create a recipe for kind of disaster. I think building a kind of trust in diagnosis is important. I think it definitely helps. I think sometimes it would be interesting with Lee. I know some of the therapists at James St. George's, they say it's sometimes that kind of builds during physiotherapy, because as symptoms start to get better, as they until they've kind of gone through that process. So, because I think we do a lot of, they can't come to physio until they've got a confident diagnosis, and I think, but sometimes, yes, if they completely strongly, I don't have this is definitely all MS, or this is definitely all thing, then probably you're not going to be able to do the physiotherapy interventions. That does make sense. But if it's kind of I'm a bit uncertain, but I can see it could maybe be this, then you can actually during the treatments get some of that. And I think it's our duty to try and convince patients that it's like, if we're certain of the diagnosis, just like anything else, but it's really not the patient's duty to just to believe. I always say a bit of skepticism is good. It's keep an open mind. These are the reasons why, but I can understand why it is complicated. You do have MS, you do have FND. It is a mix together, and sometimes it's a little bit I read this in a paper recently. I'm trying to remember which one it was. It was to do with MS and FND. I think it might have been John Stone's, but it was saying that it's kind of a sensible decision anyway. So, well, actually, what have you got to lose for exploring this FND if you think it might just be your MS, and it's not anything else? Whereas actually we're saying that it's a condition which has some potential reversibility in it. Then I think there's no harms in exploring and going down this path and seeing if some treatments can help you. So that approach sometimes might help in this patient group too.
So sort of a pragmatic, what have you got to lose type approach as well. I suppose Musa makes a good point that actually we're not always in control of investigations that we arrange. And Rachel, I'm sure that this comes to you, that people have scans done by other people, and is that hard undoing some of the jargon that comes with scans in people with functional neurological disorders who think that accords with their symptoms?
I think so. I think it matters more, as Alex has alluded to, how that scan is explained when it's done. That does more harm than the report. So I've had a number of patients who've had, some minor degenerative changes on spinal imaging, who have been told by someone that, this is terrible degenerative disease and it's no wonder you're in pain. And then it can be very difficult to unpick that if that's been the way it's been presented.
And Lee, we've dealt with a particular clinical situation here, which is someone with a very clear cut functional neurological disorder. But probably in practice, what a number of us see more commonly is someone with something a little bit more subtle, some clinical features that don't quite fit with what we believe to be the case for their multiple sclerosis. How would you how do you deal with that? How as a physiotherapist can you deal with that?
I think when we had the discussion, I think if the load of the condition is the greatest, then they need to obviously the diagnosis of FND. But we do see a lot of patients, don't we, with what we call functional overlay in varying degrees, and quite often I'll see patients with balance problems that don't you can't really get a fix on it when you're doing this directed tests, balance tests. They start doing all kinds of things that you wouldn't have particularly expected. And I think with those patients, I often explain it in the predictive coding and explain that to the patient. I don't use the FND tag because to give them another diagnosis load doesn't. I don't feel that it's appropriate, but then have an element of FND rehab and come at it from the FND approach. So tapping into more automatic movement, talking to patients that we're trying to make the movement a bit more rhythmical. The brain, they've had this episode of demyelination, the brain's used to things going wrong, and now it's got into this mode of predicting that it's going to go wrong, and we need to try and the demyelination's healed, and we need to try and see if we can get that information flowing a bit more freely. And I think I've had a lot more success from doing that with these balance issues that are kind of like a bit, do you know what I mean? A bit soft almost. They're not pure vestibular. They're not. Somebody just drifts off when they turn, or you're just getting little subtle changes.
And do you use the word predictive coding?
No, I don't.
What do you say? What do you say?
Usually it kind of saying that your brain's got used to things going wrong, so now it's predicting that the wrong things potentially going to happen. Or talk a lot about rhythmical movement as well, because when you get doing them side to side and exploring the basis of support heel to toe, often patients are really stiff, really expecting to fall, or do you know what I mean? And they've lost that rhythmical rhythm to the movement, and that seems to kind of the penny drops. I often use the escalator scenario, that you predict what's going to. Have you ever gotten an escalator that's stopped and you've not realised and you've jerked forward? So kind of use that explanation as well.
Is that what you do in clinic, Rachel? Do you talk to people about predictive coding, or do you tend to use one of your analogies?
So essentially you are describing predictive coding using something that's more accessible. So I find that having an understanding of FND and how it presents and how people experience it is really helpful for having that diagnostic discussion, because there are certain things you say, I've met other patients who have said X, Y, or Z, and often that will marry up with what their experience of movement is. I often say things feel really hard, because things are not, your brain is overthinking movement, is paying too much attention to movement. And you can talk about, sportsmen who choke in the middle of a match because they're overthinking. And that's, again, something that people have a familiarity with. So it's, it can be helpful.
Alex, the things that you've come across that really help people to understand what's happening to them that you found to.
I get I have to admit I use the escalator one too. So yes, I talk about predictive too. I do I tend to try and keep it as a for some people this is how so I tend to try and keep it quite plain if possible, which is the brain is complicated, and the way that the brain makes movement happen is complicated. For example, the brain is predictive. It's always trying to judge what's our next behavior or what we're going to do next based on all of your past experience, comparing it to all of the information that you're getting in suddenly. It would take a lot of energy to do that if you had to do it all at once. So, and then I usually do the escalator, and halfway up the escalator, it starts to normalize again because the brain is no longer predicting. The suitcase one seems really nice too, and I think that
Yeah,
would
it's
work
good.
just as well. So I'll get to
Yeah.
take that. I'll try that next week. I'll try this week even. But and then I usually talk about and for some and we know that movement really does get affected as well. Like and then I'll usually I play bass on, so I play that 1,000 times in practice. But then if I'm on stage, like it's like all of that training's gone out the window, and suddenly it's like, well, my hand doesn't even feel necessarily like, but it's suddenly when that kind of fight or flight response comes on, for some people it does disconnect from the body, and some people are a bit more prone to be disconnecting, and some people are prone to be less disconnecting. There's some risk factors associated for that, so you can there's that nice symptom model, which I think that in the physio for FND trial, I listened to a talk, and I sit with some of those physios too, so that kind of, you can talk around that quite nicely with that, because you can say, oh, here's some of the risk factors and why it helps disconnect. For some people, that might be trauma in childhood, and you disconnect the body as a coping method. For some people, it's migraine, or you have changes to your body, which means that your sensory process, all the information going up, doesn't make as much sense. And then I always try and say some people, and never say this is what's happening to you. And then I usually say, does any of that kind of resonate? And for some, it'll be like, oh, yes, the disconnection or the dissociation. I work with some of the more seizure group as well. That's really what makes sense. For some people, it's kind of, oh, that motor, and that kind of, the harder I try, the more it doesn't work, kind of makes more sense to them. And yeah, and for some people it doesn't. So but yeah, it's those are a few of my tricks, I guess.
Perfect. Well, what a perfect way to end our webinar. Alex, Lee, Rachel, I'm incredibly grateful to you for lending your expertise to an area that we're just starting to explore in multiple sclerosis. I think we've all learned a huge deal. I've learnt about predisposing, precipitating, perpetuating factors for functional neurological diseases. I think there'll be things that I think about in every patient who has these symptoms. I've been struck by how important it is to have your own concept that you're able to pass on to your patient about predictive coding, and some of the very elegant and clever ways that you've told me about how I can approach the patient. And Lee, it always strikes me just how clever your symptoms focused approach is, and how we can work with our patient to help restore their confidence in us, in the diagnosis, and what we're able to do. Ladies and gentlemen, I'm incredibly grateful to you for attending and for your questions. This is the last MS Academy webinar of the year, but there will be a full webinar program for next year, and we look forward to seeing you then. Thank you, everybody. Thank you.